This video is on peptic ulcers. Peptic ulcers are a sore resulting from the disruption of the mucosal integrity of the stomach or the first part of the duodenum. To understand how this occurs, let's first examine mucosal integrity. Parietal cells are stimulated by CCK and acetylcholine to secrete acid to aid in digestion. The stomach is protected from this acid in a few main ways. Firstly, mucus and bicarbonate is secreted by epithelial cells, and the other main factor is prostaglandins. Peptic ulcers result when these factors are disturbed. A common cause of peptic ulcers is NSAIDs because it inhibits prostaglandins. H. pylori infections can also cause peptic ulcers through disrupting mucus, potentially leading to mucus-associated lymphoid tissue lymphoma and gastric adenocarcinoma. Also, Zollinger-Ellison syndrome is a disorder that results in excessive production of gastric acid. As with most conditions, smoking age, past history of ulcers, family history, and alcohol are risk factors. So how does a patient present? Unfortunately, ulcers are commonly asymptomatic until there is a complication. Yet if there are symptoms, epigastric pain is common, and if it radiates to the back, it suggests it is severe or there has been perforation. The pain usually comes on shortly after eating due to the release of CCK that stimulates parietal cells. However, if this is not the case, it may imply there has been penetration and other complication. The patient may also have characteristic upper GI bleeds such as melena and hematemesis with a coffee ground appearance. So complications we kind of have already touched on, but a good way to think through it is by looking at the diagram. So firstly, there may be an upper GI bleed if there is erosion into a blood vessel, usually the gastroduodenal artery, the left gastric artery, or gastroepipyloric arteries. There may be perforation if the ulcer erodes through the wall of the organ into the peritoneal cavity, and this would be concerning for peritonitis and sepsis. In comparison, if the ulcer penetrates into an adjacent organ such as the pancreas or to form gastrocolic fistulas, this is known as penetration. Finally, scar tissue from the ulcer can result in pyloric stenosis and gastric outlet obstruction, and you would have projectile vomiting. To investigate peptic ulcers, we start by ensuring hemodynamic stability, especially looking for tachycardia and hypotension, which would suggest a bleed. This would be confirmed with FBCs looking for anemia. Grip and hold performed in case a transfusion is required. H. pylori or urase breath test can also be performed. Measuring serum gastrin can also identify Zollinger-Ellison syndrome. Most importantly, an upper gastric endoscopy visualizes mucosa and is the key diagnostic tool. Treatment focuses on the pathogenesis of peptic ulcers, so if you remember too much acid and not enough mucosal protection. This is commonly done with PPIs such as omeprazole that inhibits the pumping of hydrogen ions to reduce gastric acid secretion. This is usually given with 2 antibiotics, so clarithromycin with amoxicillin or metronidazole. If this is not successful, agents that suppress acid, such as antacids, gaviscon, or antihistamines, such as ranitidine, can be given. Because if you remember, histamine stimulates parietal cells to secrete acid. Finally, mucosal protective agents can be given, such as prostaglandin analogs like misoprostol. Thank you for watching. If you learned something, please tell a friend who may also find it useful.